Hi, everyone. Thank you for tuning in to our podcast. This is the Para Podcast. We are bringing research from all over the world in the context of a paramedic and so that it is understood by the man on the street. We're taking African paramedicine, we're taking it to the world in a way that we can. As usual, I have the usual suspect, Tulani Sibanda, who is in Qatar. He's CCP. And then I also have Elias, Mr. Thomas. He is in New Zealand. He's working there in the countryside. He likes a chilled lifestyle. We also have a guest today, a special guest. And I need to say this is the first female to grace a presence with us. And we are very excited. Yay!
Thank you. Thank you. I feel very honored.
Yes. And she is a doctor, which is the first doctor too. So we find, we find a lot of excitement to have that. We're a serious podcast. We discuss serious issues. People see us joking around, but we do discuss serious issues. So today it's about research. It's important that I mention this before we start. We are going to discuss a sensitive topic. It has to do with death and how we deal with death. So we're talking about palliative care. Palliative care, to those who don't know, it's when a person is at the end of their life for whatever reason, and they have accepted their fate, and they need to be cared for at home. So a lot of paramedics in the developed world, they deal with such issues, and obviously with also nurses and everyone else that is in the healthcare, they deal with those issues. So we're going to be dealing with that. If you find this as a person who's viewing a bit sensitive, feel free to not watch, because we are going to be talking about such stages, the end of life stages, and it is a bit sensitive. All right, so let's dive into it. So we have Dr. Tomi Omoya, a special guest with us, and we are happy that she is here. And I'll tell you how I met Dr. Omoya. I met her, I was introduced to her by a colleague from Flinders University. I was struggling to find a supervisor, and James Pierce, he sent first round of emails. Let me give you a background. I had tried to find a supervisor from South Africa, from Australia, everywhere. I think I even tried Canada at some point, people that are associated with Canada. I couldn't. I'll say,
how come you didn't try New Zealand?
Well, I didn't know. I even tried other South African doctors that I knew. Most of them did not respond to emails, which is frustrating. And then James Pierce is a person that I knew that introduced me to other academics a year prior. So he then sent the first round of emails, sent 3 emails to 3 people. 2 of them responded immediately, started conversations. They made me feel like there was a green light. And then he said, I can introduce you to more. The second round had Dr. Omoya. I'm not sure if I sent the email or he sent an email, but something happened. An email was sent. And then Dr. Omoya was very excited. She assisted me and introduced me to next people outside of Flinders Uni. And yeah, I'm on the right path now. That was possible around June last year. I think by August, I sort of had a light where I was going. I was hopeful. I think I struggled for more than 6 months to get a supervisor. If you were to check my emails, there's like more than 20 emails that I had sent. I was just struggling. So it helps who you know. And it also helps a lot if you know people like you in a foreign country. Yes. All right. So this is Dr. Omoya. And thank you, Dr. Omoya, for gracing us with your presence. So tell us, Dr. Omoya, this is a unique last name in Australia. Would you mind telling us where is that from?
So thank you. I am from Nigeria. So I was born in Nigeria, and I spent the first 18 years of my life in Nigeria. I am born on the southern side of Nigeria. So most people know Lagos, but I'm from a smaller town. So just down smaller town. And I'm a Yoruba. So my tribe is Yoruba. People know Igbo, Awusa, but I am from the Yoruba tribe. And sometimes my name will give that away because my name is quite long. Even the last name is shortened and the first name is also long as well, but the name gives it away. I think most people from that part of Africa, as soon as they see my name, they know, oh, she's a Yoruba girl. She's from Nigeria. Yeah.
Yeah, pretty cool. I get that a lot too. Are you from Nigeria? That's the first country that people ask where I'm from. Yeah.
Same.
Yeah.
I think my colleague still introduces me that I'm from Nigeria, the Nigerian guy. And then he'll be like, those emails that you receive, is from this guy. Him and his cousins are the ones sending them out.
Yeah.
I don't
The
know.
princes and the kings.
Yeah. The Princess and the King. That's a common one.
This
And then,
fella and his cousins, yeah.
yeah, so I'm assuming that you did year 12 or grade 12. I'm not sure what you call it, or Form 5, depending on where you are in the world, in Nigeria, and then you left. Yeah, and then what happened after that?
Yes. So I came here, so we came here the first year when we got here. I got my admission into nursing. I'd already did this pre-degree program back home, which is a year of, you're not quite in uni yet, but it's almost like getting you ready, almost like a foundation course, right? So I did that. And then when I came here, that was kind of enough to get me ready to go into university. So I got into nursing. 2 years after I came here, about a year after I came here, got into nursing, did my 3-year program nursing, and I've never really left university actually. It seems very,
You're a bookworm.
I don't know what's happened there.
One degree after the other.
It's just one degree after the other, I tell you. And I've just been there, finished 2011, did an honors program in 2000, actually, I started the honors program, did that for about 18 months. After that, went and did a graduate diploma, did that for about another 2 years, and then went straight into a PhD. And then about 7 years of my life was spent on that PhD, which finished 2 years ago, 2 years ago, right at the head of COVID. So yeah, that's my journey really. I haven't really left university. So, yeah, and I'm still there. I work there as well. So never left.
Wow.
Well done.
I thought, why did it take 7 years though? Can I just ask?
Oh, that's a good question. PhD it's a marathon. Sorry, it's not a marathon. It's a journey. It's a type of journey that anyone who's
There's a lot of emotions there. There is a lot of
I
emotions.
can feel it's coming deep.
I think I'm never lost for words, but when I think about my PhD, it's just an interesting journey. And I think about, the fact that I also got married during the PhD, had 3 lovely, beautiful boys during the PhD, got setting myself up, establishing myself in terms of getting a house and all of that. So, there's a lot that surrounds the PhD. It's an interesting journey. I think we need a podcast, honestly, to unravel the journey of a PhD. But yeah, it's a very interesting journey, so to speak.
So,
to put it
what I want to
slightly,
ask, sorry to cut you off. I think you mentioned something very interesting. I think I said it a lot now that I think about it. But just to backtrack a bit, is that I think one of the things that we need to mention about this podcast is that we've got that interprofessional collaboration, because you're a nurse, we are paramedics. So this is just to highlight that from different healthcare spaces, we want to communicate and collaborate so that we can work together in for the benefit of the patients. And you said you studied nursing, and we all have our reasons why we did the courses that we did. With you, why nursing?
Nursing, that's a good question. Actually, both my parents were nurses. So my dad was a nurse, my mom was a nurse. So it was almost like it was
in the genes.
It runs in the family.
You.
I couldn't even run away from it. Typical African, it was just that thing that was running in the family. And actually my sister is a nurse as well. So
I hope the kids will be something different, please.
Yes.
I must meet your kids, they'll be paramedics.
Away from healthcare, please.
I still work clinically. I work 1 day a week in the ED, but I think that's just enough. A lot of my friends that I know, there's a lot of burnout. There's just significant issues, especially working in an high acute environment. So I still go 1 day a week just to keep my skills up. That's all. Yeah. And I think that's plenty for me. But yeah, it's just something that I didn't really see any other thing around me. Everywhere I look, it was just nursing, and it was almost like a natural progression sort of thing.
Okay. So let's dive into the top. Before I get into that, you mentioned a postgraduate certificate or something, diploma. What did you study? Which one was it?
Yes.
What did you study?
So my postgraduate, it was a graduate diploma, and it was in emergency nursing.
Okay.
Because that was my background. So yeah, so I did it in emergency nursing.
Okay. All right.
Every other study was research based, but that one was particularly just to own my skills in emergency nursing. Yeah.
Yeah. All right. So, and then you did an honors. Did you do a master's or you did your
No,
master's?
Flinders has this thing where if you have a distinction and above in your honors, you can move straight into a PhD.
Yeah.
Yeah.
Okay. All right.
Just another pathway.
I think
Yeah.
throughout this podcast, I'm saying poo 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 because you did one.
Kudos. Yeah, amazing. Yeah.
Everyone that watches the podcast should know that research excites us. All of us in general, it's what we like. Anyway, and a lot of other topics too. I'm thinking about the one that you recorded the other day. Anyway, let's dive into it now. Let's talk about palliative care. Why did you decide to focus your career in palliative care or your research in palliative care?
I remember as a graduate nurse, which is that first year when you finish, you finish your university degree and you get your placement. We call it transition to professional practice placement. So it's a year that's like a guided learning year. So what happened during that year was my very first placement was on a palliative care ward. So fresh out of uni, you can imagine, fresh out of uni, the very first placement was in that ward. And I remember very clearly, like the day I was coming into the ward, as I was walking in, a patient that's just passed away was being carried out. And we all know that it's not a patient being rolled away. It's the morgue staff in the morgue carrier and all of that. So, that was me, my very first day coming in there. And I'm thinking to myself, what am I doing here? I've done this degree because I want to save lives. I want to help people. But here I am faced with a different facet of this degree, which is death and dying. And this is something that's inevitable. And at that moment, I just felt as if my nursing degree didn't prepare me enough. I had this feeling of lack of knowledge and skills. And I just thought to myself, how am I going to cope here for 3 months? Because you get 3 months or close to 4 months. And I remember it was such a challenging time because you get to know this patient. So they don't just come, get admitted and go. This is a long-term patient sometimes, they come in, you get to know their family members, you get to know their children, you get to know sometimes young families, you get to know them, and then they end up dying. And that also affects you. And I think as a junior nurse, that really affected me. But I knew that I didn't want to leave it that way. And I've always had some mentors that kept their eye on me through our university. So I had some tutors that just took interest in me through our university. So I went back to one of them and I just said, look, this is what I've been dealing with, especially in my clinical experience. And I don't think I'm enjoying it. What can we do? She said, why don't you do a research project about it? Do an honors. See if you're the only one that actually feels this way. Do a research project and check and see whether there are people in their third year of nursing right now would maybe feel that way because they're expected to finish in a couple of months. So I did an honors project that looked at third year nursing student experiences of death, dying, their knowledge and skills. So that was my honors project and my first introduction to research. So of course, the findings were very similar. A lot of the nursing students were saying that they don't feel prepared. They don't feel as if their degree had prepared them enough. So that's really my entry pathway into palliative care. So it wasn't something that I kind of planned and say, oh, I'm going to do palliative care. I'm going to look at the death and end of life care. No, I think it was kind of thrust upon me just because of my own personal experiences. And from there, I've kind of developed that passion. And when I started working, because I left that placement for the 3 months, I got another placement in emergency department and I saw another first set of it. And then it wasn't even done properly because I've come from a place that it was done really well, right? So another place that the environment was lacking, the setting was lacking for it. And then that informed my PhD project. So I go, okay, what are the experiences of ED doctors and nurses when it comes to death and dying? So that was my PhD project basically. So yeah, that was my
fascinating. There are two topics that frustrated me when I arrived in Australia. I'm bringing this now to paramedicine. It was mental health and how it was dealt in Australia. This thing is just different. Mm-hmm. And for me, just for context, I had worked in South Africa. I've worked in Abu Dhabi at the time. And then South Africa. It was close to 10 years of experience. Now I'm coming to Australia to relearn paramedicine. But palliative care and mental health. Now, Today we're talking about the other issue, which is mental health. Now, the palliative care. Now, I remember back in the day, possibly it was 2000, and I arrived at this home as a paramedic. So advanced life support paramedic working for a private ambulance service. I arrived there and there was a critical patient. Patient was in his dying bed. Wife told me that do not resuscitate. I could see the patient was sort of gasping, and in my head didn't register that I need to do nothing. Like I actually said, show me the paperwork. I need to see the paperwork. They looked for paperwork. There was a pastor who came into, said, show me the paperwork. There was no paperwork. I ended up talking to a lawyer. I called my EOC, my control center. I asked them, I'm faced with this situation. I could see that this person, if I do certain interventions, his life may be spared. So it was a conflicting mindset at the time. And I think this comes from the mindset that we as paramedics, we are trained to help sustain life. Yeah. And this idea that we help people in their deathbed is not something that we are familiar with. I think even now that still exists, even in the profession, even in the developed world. I think it's still the same. Other paramedics may not be comfortable around those spaces. So I think your research is really touching into something that is very tricky. It may appear like soft skills because we like the big skills, the emergency skills, the drugs and stuff like that. But this time we are assisting people feel comfortable knowing exactly that they are going, and we are trying to address that space. I find that interesting. Is there any case between you gentlemen that pops in your head around this issue, or you want us?
From my experience, I think having looked back from training, I don't remember. Maybe I was existing as a student, but I don't have memory of me learning about palliative care. And we've had cases, those terminal ill patients where they are in their deathbed, the imminent need to resuscitate them and transport to hospital. I've had some cases where I was faced with the family would say, no, do not do anything. We just called you to declare. And you're like, okay, that's unethical. So in essence, to say I was never prepared for palliative care. I was going to say, Dr. Omoya, here's another research project, but you already have one. But yeah, we were never prepared. We were never taught to, for the longest I can remember, I don't remember being taught on how to manage or deal with palliative care. With the knowledge that is coming out, we slowly but surely learning that it is important part of our practice. But also, I think from having to reflect on my experiences is that also from a general public, the people, the patients' families, the patients' families themselves, that their notion or the idea is that we are trained to be there for life emergencies, to treat and stabilize and transport to hospital. Also, the public doesn't have that knowledge to say, okay, there is something called palliative care. But yeah, that's my experience. I don't know from Elias if you share the same experiences.
Yeah, probably the same. I know that we did cover it in our final year, and I think we looked at a paper and basically just discussed the medication around it. But even then, it didn't register because it didn't feel important. It didn't feel like I would ever apply it until I moved up to the UK, and that's when it started kicking in. And you pop up to a scene and there's medication, and then you can see that this patient is not doing well. And you kind of know that this patient, they are dying. But then first point, when you first see them, you're kind of like, okay, what am I supposed to do? You feel like, this is a little bit of a foreign territory because you're not really sure how to handle it. The rest of the guys that trained in the UK know, because then they attend to these jobs frequent. But for you as an international, you're not really well versed with it. But I think that the thing that I kind of struggled with the most was speaking about death and dying, especially with the family members, which words to use, how to phrase the conversation. And I think it's a lot that comes in, life skills and, people skills, the culture and what the people expect. What kind of things can you say that is acceptable? Can you say, no, this person is dying, or like what has been done before to prepare them? So I think there is quite a lot that needs to be done in terms of paramedic training and understanding sort of like death and dying and how to sort of like have that conversation freely without feeling like this is foreign territory.
Yeah. So one of the people that Dr. Omoya introduced me to was Caleb Hansen Gage. He is in the city of Johannesburg. He works there. He is in a training college over there. And maybe he's finished his PhD, I'm not sure, but he is published around the space of palliative care in a South African context now. I'm not sure whether he did a qualitative research too, but it was something that was also interesting. And I was surprised too. There was actually some stuff that is coming out of South Africa that has to do with that. Maybe at some point we'll also have him and have a discussion with him around this. I know that he has strong feelings towards this too, because I spoke to him through Dr. Omoya. Now, you have published a paper. The recent one was in December, Dr. Omoya.
Malusi, before we head off over to the paper, I just kind of wanted to get a little bit of insight. Obviously, you having worked in can we say, was it like what unit did you say you worked in, Dr. Tomi? Sorry.
In ED, I worked in.
But where you kind of came in contact with palliative care first? That
was in ED? It was in a palliative care ward.
Palliative care ward. What's the general impression of palliative care in your region, or sort of like the area where you practice, especially in terms of patients and families? What's the sort of like overview and sort of like insight?
So do you mean in where I practice in ED or practice when I was in the palliative setting?
Let's say when you were working there, what was your impression that you got, sort of like the knowledge of palliative care from families and the patients themselves, and just perhaps maybe just a society as a whole where you live and, sort of like in that area, like let's say in Australia.
So I think at the time, this was about 16 years ago. It's amazing how far we have come as a society. And I think sometimes we still like to think that, now I'm talking about Australia as a society. I'm starting from there first. I think sometimes sometimes it's easy to say that we're death denying society, or we think death is taboo. But I think that there's a lot of achievement that's been made. For example, the voluntary assisted dying bill that was passed. The fact that the people itself, the people in the country, they're willing to actually talk about these things, shows that maybe we have a society that's not death denying anymore. So I think for me, that's the very first thing that I think about. Then we don't have any of these bills being passed. So at the time, there is the notion then around that time that death was something that people didn't often talk about. It was something that a lot of people kind of did hush about. It wasn't a dinner time conversation. And I think, on a palliative care ward, I feel as if it is different. And I've got to give kudos to the palliative care specialists. They are on a different scale, on a different level. I think because this is their area, of course, it's very different. They understand the concept of palliative care. It's a different kind of practice. It's not the practice that we do generally. You go on a palliative care ward and you feel as if you've been turned 360 around. It's like, what are we practicing here? It's different. It's about the patient. It's about the families. It's about the quality of life. It's about making sure that they get the best symptom management, however needed. And they will do anything. I mean, even if it's about getting someone to the beach, we've called ambulance officers to come and get someone. They were asking, I just want to be near the beach. I remember on that ward, we got someone down. The ambulance were able to facilitate that. So, it's on the palliative care ward, I believe that it's done well. When you're in palliative care, it is done well. Another issue is access though. Not everybody can get a bed. We're talking about a 30-ward bed or less. And there's a lot of people who need it. So that's another conversation. But palliative care ward, it's a different ball game. Honestly, it is different.
Yeah. And I think just to follow up with that, and I know from an African setting as well, death and dying is not something that we speak about, let alone plan for. Even though sometimes the doctor tells you that you have a terminal illness, it's something that is absolutely ignored. And I found the same thing here in New Zealand as well with the Maori population. And I do attend to few people, and that, the person will be in a deathbed, and, you sort of like look at the paperwork and look at the medication, and they will still tell you, no, I want this person to go to hospital. So when we speak about, and let's refer to Aboriginal people, I'm not sure if you have an experience with them, but what is the reception and in terms of, the culture around death and dying?
The culture around Aboriginal and our First Nation people it's different. And I think there's a lot more awareness now, when we talk about the sorry business, where when people are grieving and when someone's passed away, there are different requirements.
That is all. Yeah.
You know, the First Nations, our First Nations people, they've got their culture is quite rich and deep. You know, they have all of these processes and procedures in place, depending on where you come from, the land or the country where you come from. There are things that, you know, you can't do until a certain period of time, but they've got their restrictions, they've got their traditions, all of those things. So even though we are predominantly in a Western culture, so to speak, I think we need to listen, we need to hear, because there is another population that has their own set of beliefs around death and dying. So very unique set of beliefs that are very important. I think it's time we start listening, and a lot of healthcare workers don't even realize some of these things. I was hearing a little bit about some of the traditions of a particular group of people about a few weeks ago, and I've never heard of it. I didn't even know that was done. I think, you know, we're living together, but it's just vast apart.
Not true. No, thank you, Malusi. And you can.
Sorry.
Sorry.
Before you continue, what I want to ask, and I'm sorry if it's a conflicting question, is that now, obviously, your parents were nurses. That's the first thing.
Yes.
The first question is related to your parents. What were they? Did they practice before? And now do they believe in palliative care? But also, I'm not sure if you had the opportunity to go back to visit Nigeria, if you've been there a couple of times. And do you think that because you're now in a probably first world country in the south of Australia, the way things are compared to Nigeria, that is the same? Are people starting to believe in palliative care from Nigeria when you compare it to Australia?
Unfortunately, it's not the same. And yes, there's a lot more awareness. There's a lot more work that's been done, but I think there's still quite a lot to do. And I think what makes me also really think that we still need to do more is healthcare professionals sometimes don't even understand what palliative care is. And I think one of the first issue is that palliative care is a very Western word as well. When you think about the translation of palliative care into any of our languages, we don't have a language for palliative care I think of my Yoruba language. There's no translation for palliative care. And I think that's the beginning of the issue, because we're bringing this word, this particular palliative care approach into a context that there's no translation for it. There's no word for it. So we're talking about two different things. And how do we begin to look at what we do, whether it's not, regardless of whether it's called palliative care or not? How do we begin to look, okay, this is what we do. This is how we approach it. We've got our own philosophical underpinnings. Yeah. And I think that's where my interest lies now, is to say, yes, we might not do palliative care, but this is the way we do it. These are some of the things that we do. So I don't think it's necessarily something that, you know, we need to translate into Africa or Nigeria, because I don't want to put Africa into one country. But I think we have our own ways of doing, and we also need to philosophize those things and say, okay, this is what we do, and this is the philosophy behind it, and name it what it is in our own words. Because I think that word palliative care is problematic, trying to dump it down into most of these other non-Western countries itself. So I think that's my thought, if that makes any sense. I think that's the way I look at it.
I think this is going to be my last one. No, I dive too much.
Oh, sorry, before the story about your parents and what are they feeling about palliative care? Because obviously they come in this podcast, we refer to dinosaur years when they were practicing
during Malusi's time.
During Malusi's time, the palliative care. How do they feel about it? And when you did that research, did it also have an impact between you and them? Because it's something that is never there, especially as you explained, in the African culture and the African context.
Yeah. I think when I think about my parents, they've graciously read my work and they graciously follow all of it. But I think there's still a mismatch. You know, there is a mismatch. And I think the mismatch comes from, you know, God gives life and God takes life, you know.
Absolutely.
And I believe in that as well. I think the science behind it, my mom has never said anything against what I do, and my dad has never said anything against what I do. But I have a strong sense that sometimes they go, you could do topics like this, you could have done something like this. Wait, what's the reason for this one?
Do you think let's hope they don't watch this episode.
I need to track them.
They follow everything. And look, they're my number one supporters. But I just get that sense that sometimes they feel as if, look, where did this come from? Like, why did you choose
What
this?
happened to you?
It's a culture.
We didn't ready to do that.
Is this a case?
Yeah.
Honestly.
Yes.
I think the next thing that I wanted to touch on, and I know we are gonna have different types of viewers.
Yeah.
If we can just define palliative care and sort of just like speak a little bit around what palliative care is and what interventions are done to facilitate the process of palliative care.
So palliative care is referred to, if I just make it a bit more defined, is referred to symptom management. The management of symptom of someone that has terminal illness. And it's not a death sentence. And I think that's the thing. When people hear you're now in palliative care, they think, oh, that's the end of the world. You're dead already. That's not what palliative care is. It's
Technically,
No, don't do it.
Don't do it. Don't do it, Elias.
Because there are people that they have benefited from palliative care who have longer than 12 months of life to live. They've got chronic complex illnesses that require some kind of palliative symptom management to give them that quality of life, however short or however long it might be, to help them to make sure that they can have that quality of life while they're still living. So, and it's not just about the patient alone. That's why palliative care is really important, because it's an holistic approach, right? It's the family, it's the patient, it's their loved ones, it's their carers. So working together to make sure that everyone's looked after. Yes, the patient is the main person, but everybody around them as well comes into the picture, and making sure that they're all well looked after holistically. Because at the end of the day, the way I like to define it in a simple way is that if I'm going to say I'm putting fluids in, or I'm putting it in an IV, if that IV access is going to cause more discomfort, what's the point of giving the IV? What's the point of giving them the fluids if we're going to send them into an APO or fluid overload them, and then they become more uncomfortable? So to me, it's about the benefit and the risk. So weighing and thinking, okay, what's the benefit of this treatment to you? I mean, I'm not saying that don't give treatment, but I think it's important in Power Care to know that if I give this treatment, how does it benefit the patient in terms of their quality of life? So it's just something about weighing up the benefit and the risks when we're looking after patients in that phase of life. Yeah.
Yeah, no, that covers it all. Yeah, and just to any junior paramedics that are watching, if you turn out to a scene, usually you might find some morphine or midazolam. Sometimes you might find them with a sort of like a subcutaneous line in place already. Just, let that sort of like raise your suspicion that, it might be, and start asking the questions around that. But yeah, over to you, Malusi.
Yeah, this is fascinating. When you're talking about the African perspective, in my head, I was also thinking about, it's very important to respect people's cultures and what they believe in. I understand when you're talking about the paradoxical belief with your parents that they have their own belief system. Yes, they understand what you're doing. Look, as a person who's from Africa, we know that people believe in ancestors. They will believe that their ancestors should be expecting you, or they can talk to God on your behalf. Therefore, we as people that are living don't have any rights in saying that this person is going to die. Who are you to say that? And other people believe in God. God is a giver of life, as you said. So it's a lot of belief systems. Therefore, it's also very key that if there's a system, as you said, the philosophy is developed in a way that is pro-African, understand the African concept and all that. Now, this takes us to the next set of questions. Dr. Omoya has published a paper, the recent one, as I said earlier, published in December 2024. He published a paper with two other researchers, I'll call them. So it's him, Dr. Omoya, and there is Thomas Joroge, he's, I think, from Kenya, and then he's Australian now. And then there is also Anita De Bellis, who is from Flinders University. So the paper is a qualitative evaluation of palliative care education program for paramedics. So that is what actually made us to have here. to discuss this paper. This is a great paper. I've read it myself. Now, tell us, why did you do qualitative research for this paper? I know this is not a difficult question for a doctor like you.
No, it's no. Honestly, I am a social researcher, and I think most of us, when we get into the health profession, it's because we have that degree of, we want to help people. We like talking to people. We like that kind of communication and conversation. And that's just a natural progression for me. I like to socialize. I like talking to people. I like hearing about people's stories. So for me, numbers won't get me there. Because I need to hear about the whys. How did you get here? Why? What was your thinking? How are you feeling about it? So for me, I call myself a social researcher. I've done quantitative research, but I'll always speak qualitative any day.
Yeah.
I'll always speak that.
And then
I used to be a numbers guy, like quantitative. I enjoyed it.
Yeah.
And then when I started with qualitative, I'm like, sure, what did I get myself into? But now that I'm in the process, I think it's a bit of both is good, a bit of understanding. And I think it gives you that you can't get the people's feelings. I mean, the topic that you did, which was on palliative care, to get the experiences of the paramedics, which we'll talk more about as we talk about the paper. You cannot get that from qualitative data, and that makes it the beauty of qualitative research. Yeah. Sorry, Melis.
No, it's good. It's good. We're talking about research now. Everyone is awake.
Look at you. You're smiling.
Yeah.
Even Elias.
Why was the approach, the interpretative phenomenological approach, appropriate for this paper?
Phenomenology, of course, is about studying the lived experiences of people, isn't it? That's what it is about. And we know that there are different forms of phenomenology. There's the descriptive one and there's the interpretative one, which I've done. The interpretative one it just goes a little extra layer. Rather than just describing, you look to interpret the hidden meanings. So you're looking for, because someone can we could be having a conversation as we are right now, but there are also hidden meanings that can exist in those conversations. So as an interpretative approach, you're not just uncovering what they're describing, but you're looking at the whole picture and trying to bring out whatever might be hidden and trying to interpret whatever they're saying as well. So I like the interpretative approach because it's richer. I'm not just saying this participant said this and said this and said this. It gives me a chance to also bring in what I believe is important in what they're saying, in the way I have also interpreted it. I've presented my interpretation of what they're saying. Yes, it does have its own bias. And, because we all have prejudices, we all have our own beliefs about things, our own foreknowings. They call it foreknowings, means that you come with your own idea of what you think is important, right? But what is important as a qualitative researcher is that when you're using those methodologies, you need to make sure that you're reflecting on your own understanding, on your own foreknowings, on your own biases. And there's a section in the paper that talks about the researcher's position. And that's just me really spelling out and saying, these are the understanding of what I think about this area. These are the things that I come with already. Me spelling all of those things out means that I am aware of them in the first instance, so that when I now start writing, I can write clearly in the sense that I don't let that cloud my judgment. I'm now informed by, okay, this is what my participants are saying, and it's not informed by what I think or what I think is important. Really, I don't matter. They are the ones that matter. So, yeah that's why I use that.
Sorry, Medicine. I'm going to off rent you.
It's
When you watch, before TikTok was Instagram, and you see, and I'm saying that, I'm going to offer. When you watch Nigerian videos on TikTok, they use big words.
Discambombulas.
Big words. Some of them are long, and you mentioned a word that I've never heard before. What is it for? No, that I can't even pronounce it.
Phenomenological approach.
No.
Foreknowings.
Foreknowings, yes. I don't know. I know I'm going to sound silly, but how do you even spell that and explain it?
You don't sound silly at all.
that will help someone else, but more important for me. Yeah.
Yeah, no, you don't sound silly at all. And these are all just research jargons. And all it just means is that my preconceived ideas. So for knowings, that's FORE, knowings. So what I know before
Yeah.
I
For
come
knowing.
into the research. Yeah, for knowing. So it's just my own biases, my own prejudices, which are clearly stated out. I think on what, I'm not sure which page it is on, but there were things around being an ED nurse. I see paramedics of paramedic officers come in, bring patient in, and I always think to myself, why are you bringing this person in? They're obviously dying. They probably don't need to be here. This environment doesn't suit them. So it always used to get under my skin. I'm like, this is something that you could resolve at home. And I think
We apologize.
On that
I
behalf,
think, doing this research also made me realize that there's two sides to the story as well, because there's a whole lot of things that's going on that I don't also realize. It was easy for me to just point out and say,
What's wrong with
why are
this?
you bringing them here? They can just, this is
Yeah.
wrong.
Yeah.
But I think going into the research as well, I learned that there's a whole lot of other issues that goes on in the background. It's not justice. So yeah, and I think that's just some of the things that come out of research, and I love it. I love it. That's what I love about research.
Yeah. You see, my next question you've answered, Dr. Omoya. It was going to be about consolidated criteria for reporting qualitative research. And you've touched about that. That is when you talk the position of the researcher and basically your own biases and all that. How does that influence the research itself? I remember Tulani asking about that at some point when he started, because I did my master's in qualitative research and he wanted to understand that. So let me continue now. So in your paper, you sort of found about 4 themes.
Yes.
Yeah, 4 themes that you find. I can read them just to refresh your memory if you want.
Yeah, thank you. Thank you.
No, I saw your face. So go and read the paper. The paper is not on open access. If you have working for an organization, most of them, even GPG has those access to these kind of papers. I mean, Gauteng provincial government. If you are at a university, you'll have access through your librarian, or they'll tell you how to access these papers. So it's these are the themes that we found on the paper. We found, not we found. I wasn't involved. So it says. It says
you immersed in the paper, so that's good. I like
how
it.
deep he is into it.
Yeah. So it says that the benefits of the education program, that was one theme, and the gap in the education program and responsibility for the education provision and suggestion for the improvement of the education program. To just give a bit of background to those who have forgotten the title of the paper, a qualitative evaluation of a palliative care education program for paramedics. So there's a program that has been designed for palliative care management for patients. Therefore, Dr. Omoya and her colleagues therefore evaluated the program to see how do the people that are actually practicing that feel about the program. And those are the themes that came about. Tell us more about these themes from your research.
Yeah. So I just want quickly, before I go into the themes, I want to give a shout out to South Australia. I think South Australian paramedics were an exemplar. I feel like I'm putting we. I'm putting we. Because
I mean, they bring dying patients to ED, but okay.
I'm just claiming it right now that I feel like South Australian Ambulance Service is a great exemplar in taking the lead in doing a lot of things in this area. And I think the rest of the country probably, hopefully will catch up, but I think there's so much that's going on. And South Australian Health recognizing the import of having South Australian paramedics doing this in terms of hopefully reducing emergency, unnecessary or unrequired ED transfer, I think is phenomenal. But that's on the side. So going to the themes, yes, we found the first one was on the benefit of the education. And we found some things that people who were involved in the education found that it was beneficial to their practice in the sense that it actually did decrease their ED presentations. So they were not having to take everyone to the ED that needed palliative care. Rather than, I think pre this education, they felt as if they didn't have the tools or what was required if they were to go to those patients. But after the education program, they felt as if now I kind of have what I need and I feel a little bit more confident to be able to address these things and even start some form of treatment. But one thing that we found was that most of the people that found it beneficial were actually junior and younger paramedics. So that came out. I did want to emphasize and that makes sense in a way, because the more senior paramedics felt to see if we've been there, we've done that, we've got the experience, we know what to do. And I'm talking people with 26 years, 30 odd years experience.
And also, yes.
Do you think this kind of like, is it because they feel like they know, or did they actually know?
Who knows? And I don't think that came out, but the consistency of what came out was the fact that the younger 4 years below were the ones that found it useful. But the thing is, most of the older ones have probably had to learn on the job as they go. And I don't know how beneficial to them that is. If they'd also been exposed to that kind of education, I think it would have been beneficial to them. But most of them have had to just kind of learn, go out and do their own education program, enroll themselves in graduate diploma, and, done some palliative care course here and there, just to get themselves up to speed. Yeah. So, that was the key difference. Yes, it was beneficial, but we found it more beneficial for the younger ones, for the newer paramedics. And even the older paramedics, the more matured experience, I shouldn't say older, the more experienced paramedics also found it beneficial on behalf of the newer ones, which was interesting because the more experienced were saying, oh, we found that it was very helpful for them. Actually, they were able to realize that you can't save everybody, because they come on with this cape of Superman cape when they finish. So I think that education was beneficial for them to be able to see. Yes, it was beneficial, but you just have to kind of think about it. Who was it beneficial for? And I think that also made me think that how much impact does education have? Is experience more beneficial than education? And I think this is just my thoughts, and these are the things that I think about in my own time, in my own reflection. I think is education, like, can education ever prepare you enough? Do you just need to be on the job and learn on the job? So that's something that I haven't found an answer to. So I'll leave it there.
Look, this has been great. I feel like we just opened. We haven't even started. You're very informative and I can feel your passion. Yeah, we have to round up because of time, unfortunately. But one last question. If you had a chance to introduce this topic in the African context, how would you start? Let's say in Nigeria.
How would I start?
In Nigeria, where the people that you know, how would you start?
I think first to start, we don't have the education is lacking, because at least we gotta have an education to even evaluate. And I know I don't want to dismiss the amount of work that quite a number of people are doing, but is it enough? We need more people doing that work. So at the moment, actually, I'm working on a project that's looking at the educational needs. So it's like an assessment need project. So it's looking at the education needs of Nigerian doctors and nurses. I've just kind of want to kind of start there because, of course, Africa is big.
Yeah.
I would just have to start somewhere. So what I'm doing now is I'm doing an educational needs assessment, because it's easy for me to just go, oh, we've got this palliative care education program that's readily available in our own Western setting here, and just go, I'm going to dump it there. That's not going to work. It's just going to fail. It's going to be, it's not going to cut it. So the first thing that we're doing as a team now is that we're conducting focus groups, and we're not there yet. We're just going through the ethics application. But what we're doing now is that we're going to conduct focus groups on cancer specialists, people who are cancer specialists, doctors, general nurses. We're going to get them together in a room and say, okay, if you were to design an education for palliative care, what would you like to see? And within that as well, we also want to assess their own experiences, their baseline understanding, what they know, so that we actually know what we're working with. So once we get that, we're going to gather what we found and develop a course that someone based in Nigeria who is an healthcare professional that wants to know about palliative care can easily access and say, okay, it's an 8-week module course, however long it is. We're just going to follow this. So that's where we are, and that's what we're hoping to do. And I think that's the way I would go about it, because I've seen a lot of westernized version of palliative care, been, people trying to use it on us and trying to see how it works. But I've seen that it's different. There are some significant differences. And I think hopefully this research will bring out some of those differences, and then we can do the education and hopefully then assess people and see and evaluate the education program as well. So if I'm going to do it in an African context, that's the way I'm going to start.
It's like I knew
there's a lot of
working on a program already. Yeah. I'm interested. Is there a Delphi study involved there or nothing? Not Delphi study to create a program?
No. So it's we can call it a Delphi study. Actually, it would work that way, because it's almost like a pilot of some sort, just to kind of get to what we want to get to. So, yeah.
Yeah. So I think, sorry, Melissa, I know we're pressed for time. Just want to mention this, that I think you mentioned something which is key, and something, you're the second, you're the third. I don't know. Anyway, you're one of the guests that we've had. One of the guests that we interviewed was talking about mental health, and he mentioned the importance of contextualizing healthcare within the African setting, not taking what the Westerns are doing to Africa. And because if you have to look at healthcare in South Africa, there's a whole lot of local beliefs, the traditions, the practices, and trying to impose those Western models without adaptation can lead to mistrust, probably, but most importantly, like ineffective care for our patients in the African context. So I think that's key. What you mentioned there is that it needs to be tailor-made for Africans.
Absolutely.
Thank you very much, Dr. Omoya. We appreciate your time. By the way, the patient that 2012 that I had, I actually transported to hospital.
Wow.
I would have been one of those people who would have said, "What are you doing here?"
Yeah. Look, having learned that, I wouldn't have, or if there was proper paperwork that was talking to that, it was going to be great. Yeah. And having the information that I have now, I think I was going to take different strategies in managing that patient. We do practice a lot of palliative care in the States, and I can say I'm fairly comfortable dealing with those cases. Anyway, thank you very much, Dr. Omoya. We appreciate your time. We have stolen time from our family, and we
No, that's fine.
Please apologize on our behalf, but we also thank you for your time. Highly appreciate your time. We hope to see you after you publish your research that you're currently doing in Nigeria. We'll have a chat about that. This was a great episode, and we appreciate you.
Thank you. Thanks for having me. It was a pleasure. Thank you.